morning, everyone. First of all, I'd like to thanks to APMF committee who has already inviting me to this very beautiful congress. My talk is about major challenge ovarian PRP injection for follicular activations. As we know that premature ovarian insufficiency or POI, formerly known as premature ovarian failures, means the loss of normal ovarian function from a variety of causes before the age of 40. Roughly 1 in 10 and 100%, 1 in 100 women have POI, and often the diagnosis is extremely delayed. About 1 in 1,000 women even are affected under the age of 30. The use of POI less emotive than the formerly used premature ovarian failure. If you look number of papers retrieved in PubMed in 2015, the use of primary ovarian deficiency is the second after premature ovarian failure, following by others such as premature ovarian insufficiency. And what happened with POI? In POI, we are facing these problems, menopause and reproductions. In menopause, patients are at risk to suffering from the short-term symptoms or long-term symptoms because of menopause. And then in reproduction, of course, infertility and menstrual disturbances are the main symptoms of POI. The etiology of POI can be caused by genetics, autoimmune, or iatrogenics that induced by radiotherapy, chemotherapy, or ovarian surgery. The POI caused by exhaustion of the pool of pyramidal follicles that we know that the pyramidal follicles, the maximum, the number of pyramidal follicles is happening 15 years old. So that's why if something happened before 15 years old because of genetic causes, or even after 15 years old because of iatrogenics or infections, the maximum fertility, as we know, in the 25 years old, declining of the number of pyramidal follicle, it will induce the patients come to the POI conditions that also can affecting their fertility. Activation of dormant follicles is new treatment for POI. It's published by Kawamura in 2016. He introduced that pyramidal follicles are dormant in the ovary, and then several intra-ovarian factors such as KIT ligand, neurotropin, VEGF, BMP4, BMP7, LIF, fibroblast growth factor, and keratinocyte growth factor have been shown to be important for pyramidal follicle activation from the dormant state. Although the exact mechanism how a limited number of follicles are activated among the huge number of dormant follicles are still unknown, recent studies demonstrated that intracellular signaling mechanism is important for activation of dormant pyramidal follicles. So this is the concept of Kawamura studies, a scheme for in vitro activations. He did under laparoscopic surgery. One or both ovary from POF patient were removed and then cut into cortical strip before vitrifications. And then histological analysis were performed to detect residual follicles. After thawing, the ovarian strip were fragmented into 1 until 2 millimeter cube and cultured with PI3K stimulator for 2 days. And then after culture, cube were washed and autografted beneath serosa of fallopian tube. And then he said he observed that follicle growth was promoted by FSR treatment. And then when the follicle reached pre-ovulatory state, mature oocytes were retrieved and fertilized with husband sperm in vitro, following by embryo transfer. Several factors have been observed to inhibit follicle activations, including MH, stromal-derived factor 1, and member of C, Jun, and terminal kinase pathway. This review summarized the findings from studies of these factors and discussed their potential integration into ovarian tissue culture strategy for fertility observations. This is the molecular pathway regulating primordial follicle activations. The PI3K AKT mTOR pathway has many substrates, which include molecules regulating cell cycle and apoptosis. AKT can phosphorylate phosphoxylate 3A and cause cytoplasmic localization of these transcription factors that can be inhibit the primordial follicle. And we can see also the P10. P10 will inhibit primordial follicle activation. That's why P10 inhibitor is very, very much important for follicle primordial activations. The molecular regulation of primordial follicle growth activation in mice, this is for the activators, including the BMP4, 7, VGF2, VGF3, GDF9, then KIT ligand, leaf, TNF alpha, and again, we can see the P10 inhibitor is very important. This is PI3K, AKT pathway, phosphorylase FOXO3, and then relocation into cytoplasmic that can be inhibit the follicle activations. This is the inhibitors, including hyposignaling pathway. In the human ovarian anatomy and tissue handling for fertility support and preservations, the follicle in vitro growth of the follicles through the follicle activation is quite important. So that's why through the Kawamura study, the some point we can learn that IVA, in vitro activation follicle approach, leads to new infertility treatment strategy for POI patients to conceive their own genetic children. The IVA is effective in POI patients who have residual follicles, but there is no established method to predict the presence of residual follicle before IVA treatment. In addition to POI patient, IVA is suitable for treating infertility in patients with diminished ovarian reserve and in cancer survivor following germ cell damaging therapy. At the moment, platelet-rich plasma has become a novel treatment in various aspects of medicine, including reproductive medicine, more specifically focusing on infertility. What is PRP? PRP consists of high concentration of platelet found in plasma obtained after centrifugation of very freely collected blood, and then platelet carry more than 800 type of protein molecules, cytokines, hormone, and chemoattractant. The activation of platelet induce the release of variety of biologically active proteins, which stimulate cell proliferation, growth, and differentiation. This is our study using mice models. We established the POI animal model, mice using platinum-based. You can see after 1 week, 1 month, 3 months. Yeah, this is we can see the FSS level after we do the intervention with platinum-based. The FS level increasing after 1 month, and then 3 months with the different dosage, and then the estradiol level declining after we succeed establish animal model. And then also this is the number of follicle, primary follicle, growing follicle, and atrophic follicle all decreasing in animal model of POI. How the serum AMH in POI patient animal model after PRP? We did the PRP injection, and then following PRP injection, we can see in the platinum-based 3 months or 5 months, the level of serum AMH increasing. This is compared to the control. And also the serum estradiol, after injecting the PRP, serum estradiol is much better in the both of groups compared to the control. And then we are trying to explain actually what happened after we do injection of PRP intraovary. Then if we look the FOXO3, this is after PRP injection, FOXO3 increasing, and then phosphorylation, and then DDX4 that related with stem cell, organelle stem cell, also increasing after a PRP injection, unless in patient after in animal model after 5 months receiving the platinum base. What is the effect of intraovarian injection of autologous PRP on ovarian result and IVF outcome parameters? This is study we aim to determine whether intraovarian injection of autologous PRP improve response of ovarian stimulation in IVF. The method PRP injection was performed transvaginally under ultrasound and under anesthesia, at least using one ovary using 17 gauge single lumen needle. Injection was done underneath the ovarian cortex to the subcortical and stromal areas, and even the patient with small fibrotic ovarian tissue making much difficult, but we still do injection. They still do injection 2 until 4 millimeter of PRP. It was challenging, and after the procedure, patient were taken to the recovery room and observed for 30 to 40 minutes. We can see in the study the patient with POI who underwent PRP procedure, even they lead to spontaneous pregnancy and then live birth. And then the patient underwent ovarian stimulations, reactive oocyte, embryo transfer or storage, then fresh and frozen embryo transfer, the pregnancy up to 13 patients, and the live birth about 9 patients. What about the follicle count, AMH, and serum AFH? You can see the what of AFC and serum AMH are increasing after PRP injection, while the AFH is not so being affected. This is again one of study reactivating ovarian function through autologous PRP injections in the POI patient, perimenopausal, menopausal, and responder women. Study is quite interesting. You can see how they did the screening of eligibility responder according to the Bologna criteria. POI should the patient below than 40 years old, and then if it's level more than 25. The perimenopause, the patient age more than 40 years old with menstrual cycle irregularities, irregular menstrual cycle, and then menopausal women is more than 45 years old, suffering from menopause at least for 12 months. This is the poor ovarian response group. We can see the patient age is about 38 years old. And then this is the prior ICSI cycle, this first cycle, second cycle, and then this is post ICSI cycle. You can see how the difference, the number of oocytes is significantly increased, number of embryos, and also good quality embryos, and then the cancellation rate is significantly decreased or declined after the patient received PRP injection. Also, the same finding we found in the PRP in POI patients. This after 3 months injections, MH level is slightly better. Estradiol also increasing. In the AFC also increase, and then we in the PRP success they have number of pregnancies, number of live birth. How about in the perimenopausal groups? Also, it's not the really difference. The menstrual cycle duration is much better compared to the before, and then also the level of AMH is increasing, level of estradiol, number of AFC, and also we can see number of pregnancy achieved and number of live birth achieved. The last in menopausal group also the same. Menstrual cycle duration, FSH is still a little bit lower, MH higher significantly, and also AFC is higher significantly, and also they have still a number of pregnancy and number of the live birth. The other study also trying to see how the effect of intraovarian autologous PRP in the poor responder patients with POI patients. And we can see here 50 women in poor responder, 21 women in POI. This is the cycles before PRP and cycles after PRP. The total dose gonadotropin is decreasing. Also, the mean days of the stimulations, number of oocytes increase, number of cleavage stage embryo increase, and then number of transfer embryo also increase. And then you can see the clinical pregnancy much better in the second group after receive PRP injection and also live birth. I think this is very important. How the triggering the shift from primary to parental follicles might explain the delayed effect of PRP until 60 to 90 days compared to the below 30 days. I think this is very important to explain our patient about this. And this is one of the case that we have in the clinic. This is a menopausal patient, for perimenopausal patient, 48 years old, suffering from IVF failure more than 10 times, severe oligospermia. This is the some obesity. And we can see after injection of PRP, two or three cycles PRP, then we can do injection with gonadotropin. We can retrieve the beautiful cleavage state of embryos on itself. And now this embryo is still frozen. So, according to my presentation, there is some important key point. Number one is that autologous intraovarian PRP infusion may restore ovarian function, enabling reactivation of the folliculogenesis process through a active pathway or organelle stem cell, recovery menstrual cycle, and enhancement of the hormonal profile. This may in turn enable achievement of pregnancy even via natural conception for certain women that are still exploring option on employing their own gametes. The question for whom, when, how often, along with concurrent on preparation method and administration technique of PRP still remain to be answered. So that's why further study should be done. Then future study are required to provide concrete evidence instead of the holy grail managing ovarian insufficiency. Very important to conduct well-designed RCTs to identify the profile of women who may benefit from the clinical application of PRP. I think this is my presentation, and thank you very much for your kind attention.